I think we're going to give it a moment to let people join. Okay, I'm just going to give it another minute to allow people to get onto the Zoom before we start. Okay, I think we're going to go ahead and get started now. So thank you everyone for attending our provider reporting for cost growth benchmark program webinar today. And just to let you guys know that we will have a section at the end for Q&A. So if you have any questions, just save your questions till the very end. We have quite a few slides to get through, and we just want to make sure we have enough time for all the content. Also, we want to let you know that this webinar is being recorded. So if you ever need to reference this for additional information, just know that it will be saved on our website. So I'm going to go ahead and get started with introductions with myself and the team. So my name is Rochelle Bogue. I am the Cost Transparency Manager. I help oversee the Cost Transparency Board and the subcommittees that report to the Cost Board. And I'm going to go ahead and turn it over to Sheriel, who is going to be helping with the presentation today as well.
Hi, everyone. Good afternoon. My name is Cheryl Namingit, and I'm the Health Economics Research Manager. And I am joined by Ross McCool, who is our lead research specialist, and we will try to explain the provider reporting and the methodologies used and answer all of your questions during this webinar, hopefully.
Ross, do you want to introduce yourself?
Ross McCool, analyst for the Healthcare Cost Transparency Board. I think Cheryl did a good job introducing me already. Thank you all.
Thanks, Ross. Thanks, Cheryl. And then Cheryl, if you want to take us through the agenda, I think is the next slide.
Are you able to see my slides?
Yes, I can see your slides.
Okay, perfect. All right. So for today's webinar, we will proceed first by discussing the goals of the webinar. We aim to help provider entities who are receiving the provider reports to understand the data source and be familiar with the content of the report. We also want to help providers understand the different methodologies used in the provider reporting. And hopefully, we also would like to hear from providers on any feedback that you have on the report template as well as the methodologies. So to accomplish these goals, we have developed the following agenda to be covered in today's webinar. We will present the overview of the Healthcare Cost Transparency Board, or the Cost Board, And then we'll also provide an overview of the data call process, which is the sole data source of the provider reports that you will be receiving soon. We will talk about the overview of the provider attribution methodology used by carriers to attribute spending to providers. And then we'll provide an overview of a provider report template so that we can understand the contents across the different tabs. And then we'll also explain how we are going to compare provider performance against the benchmark in the future. We'll also try to explain, if we have time, the different methodologies used to calculate the variables in the report template. But if we run out of time, we have wrote like a very detailed documentation on these methodologies, and also an example, a sample data and example calculations, so you can use the sample data and try to replicate to be able to understand the various steps. And then last but not the least, we will provide means on how providers can provide feedback to the board. So before we proceed, I would like to inform everyone that we sent the following materials that we will use in this webinar. We have sent the slides, as well as the provider report template, as well as the write-up on the methodologies, and then the sample calculation. So it should be attached in the invite. Now, for the first item in our agenda, which is to discuss the overview of Washington Healthcare Cost Board Benchmark Program, Rochelle will discuss this, and then I will take over. So Rochelle, take it away.
Thank you, Sheriel. So like Sheriel said, I'm going to do an overview of Washington Healthcare Cost Transparency Board in the benchmark program. So with the passing of House Bill 2457, the Healthcare Cost Transparency Board was founded, and they are charged with establishing a healthcare cost growth benchmark, analyzing total healthcare expenditure, identifying trends in the healthcare cost growth. And this is with the goal of helping the state of Washington to control healthcare costs, and then identifying entities that exceed the healthcare cost growth benchmark. And in doing that, they provide recommendations to the legislature for lowering healthcare costs. So where the board is currently at in this process, the board established the benchmark for years 2022 through 2026. It's already conducted the pre-benchmark analysis of total healthcare expenditures for the years 2017 through 2019. And the board also identified trends during that period. And this specific data call gathers data for the years 2020 through 2022, which will include the first year of benchmark analysis for the year 2022. Next slide, please. Okay. Oh, I think, did it skip ahead? Cheryl, there we go.
Okay.
So board membership is governed by legislation, which is comprised of governor-appointed agency and purchaser representatives. And the board is advised by 3 formal committees. The first is the Advisory Committee on Data Issues, which is comprised of economists, researchers, and other data experts who are able to provide feedback on data calls and data analysis on existing data sources. And they help determine cost drivers in the state of Washington. The next advisory committee is the Healthcare Stakeholders Advisory Committee. And this was formerly known as the Advisory Committee of Providers and Carriers. And with the passing of House Bill 1508, that has been changed. The name has changed, and it has also been expanded. And this will now be made up of representatives of consumer organizations, labor councils, and business organizations to provide expert level advice from multiple perspectives in relation to healthcare trends in the state of Washington. And then the third and final advisory committee is the Advisory Committee on Primary Care, and they develop recommendations related to the state's 12% increase in primary care spending growth target. They make policy recommendations in relation to primary care, and they bring that to the cost board for their review and consideration. So the cost board takes in all of this information throughout the year, and They wrap that up into their recommendations in their annual report to the legislature. Next slide, please. Okay, so the benchmark data call is conducted annually, and it requires carriers and other entities to submit healthcare data to the healthcare authority. This data is utilized to calculate the state's total healthcare expenditure and measure benchmark performance. So this chart here, you can see what the rates are per year for 2022 through 2026. So you can see it starts off 3.2%, and then it goes down to 2.8 by 2026. Next slide, please. And then this here is an illustration of the benchmark cycle. So it starts with data collection, and then from there, the cost board measures, analyzes, and reports, and then identifies opportunities and strategies to slow cost growth. And then from there is the implementation phase. So they implement strategies to help slow cost growth. So each year we will go through this cycle for the benchmark. This will renew and begin again. And so each year analyzing, identifying new trends, identifying new strategies for slowing cost growth here in the state of Washington. So this is an ongoing process. Next slide, or is that the last slide for me?
It's the last slide, yeah.
Oh, okay. I'm going to go ahead and turn it over to Sherrielle now, and she's going to talk about the data portion of the presentation.
Yeah, so the second item in the agenda is to discuss the overview of the Healthcare Cost Transparency Board's data call process, which again is the sole source of the provider reports that we will be generating and sending to providers. So in the 2022 data call, the board has collected 2017 to 2019 data, we recently launched the 2024 data call, and that data call aims to collect 2020 to 2022 data. So we asked carriers during the data call to submit claims and non-claims data by year, insurance categories, and providers. We also asked non-carriers to submit aggregated healthcare related spending to add to the carrier data, and so we can calculate the overall state spending and cost growth for the state. So in the next slide, we will explain the type of data collected, but before that, let me provide quick timelines on these data calls. So we have two data calls. The first was the 2022 data call, and this was initiated in August 2022. Submitters submitted data by October 2022, and then we validated the data from November 22 to October 2023. And since this is the first time, it took a long time because there were submission errors. It took us some time to receive response from submitters on questions that we have on the data. And then in December 2023, we reported the analysis to the cost board. And so 6 months later, here we are in this webinar, and we are explaining what the provider reports are that we will generate sometime in end of June to early July. And we will send this to large provider entities, and then we welcome feedback from providers on the reports that they will receive. It is also worth noting that for this data call that collected 2017 to 2019 data, there will be no public reporting. And so providers will just have information and their own performance. For 2024 data call, we launched this in February, and we received data submissions. All carriers submitted it by May 15. And we are currently validating the data and on track to finish data validation by July. We will conduct analysis and generate carrier and provider reports sometime in August and October. And again, for this 2024 data call, there will be a separate provider reports on 2020 to 2022 data. Providers will have the opportunity to look at it and provide feedback. And then in December, we will have the first public reporting of the data that we collect from the 2024 data, meaning we will look at the performance of all carriers as well as providers compared to the benchmark. So moving on, this slide discusses how carriers submitted data, which is the source data for the provider reports. So carriers submit data by populating data submission template, and this template can be found in our webpage. And this submission template has 6 tabs. Number 1, we have the cover page, the total medical expense tab, the standard deviation tab, line of business tab, and the RX rebate tab, as well as the reference tables. So the most relevant information that we will use in the provider report is this information that we get from the TME tab. And this one collects information on member months, claims-based spending, and non-claims spending by carrier, reporting year, insurance category, large provider entity, age band, and sex codes. It's important to note that we have information on truncated spending, and we will explain how truncation is done and the role of truncated claims spending in our provider reporting in the next slides. And then the other slide, which is relevant to the provider reporting, is the standard deviation slide. This tab requires carriers to submit information on member months, truncated claims spending, and standard deviation of truncated claims spending, PMPM. And this standard deviation is going to be used to calculate the confidence interval of the cost growth of each provider and carrier. So let me explain the different data aggregation that we have in the data. So we can, the data is grouped by carriers, and the following 13 largest carriers in the state are required to submit data. Member months, claims, and non-claims data are also grouped by insurance categories. Such categories can be grouped into broader market grouping. So for example, we can group dual and non-dual Medicare insurance categories into overall Medicare market. Member months, claims, and non-claims data are also grouped by age bands and sex codes, and this grouping is important when we adjust for age and sex risk. Member months, claims, and non-claims are also grouped by providers. We required data for 33 identified large providers in the state. We identified these large providers based on a survey of carriers, which gathered data on each of their providers' total cost of care contracts and the number of covered lives associated with these contracts. And a provider is said to be large and identified to be part of the data call if it can potentially accumulate 10,000 covered lives across all carriers. So now we will proceed with the provider attribution methodology. So how do carriers attribute spending to specific providers? Provider attribution is done by first attributing individual members to a primary care provider, and attributing a member to a PCP is based on number 1, member selection. This means that members who were required to select a PCP by plan design should be assigned to that PCP. For members not required by plan to select a PCP and are attributed to a PCP during the performance period pursuant to contract between the carrier and the provider, they should be attributed to that particular PCP. And for those remaining members, PCP attribution should be based on the member's utilization history. And carriers may apply their own primary care-based methodology when attributing a member to a PCP based on utilization. So once the members are attributed to a PCP, the PCPs are also attributed to to large provider entities based on carriers' contracts with large provider entities for financial and quality performance assessment during the reporting periods. And spending on members who cannot be attributed to a PCP, or those PCP cannot be attributed to a large provider entity, are reported in a separate bucket or aggregated to the group of members that are called unattributed to a large provider entity. So that's 999 in our large provider code. So now that we understand the provider attribution methodology, we will now proceed on understanding the provider report. So provider reporting, as mentioned earlier, is not going to be public for 2017 to, sorry, this one should be 2019. For 2017 to 2019 data, report for 2017 to 2019 data will be available in June, July 2024. Public reporting for the 2024 data call will be provided, will be required for providers with 10,000 covered lives. And reports will be sent to providers for feedback tentatively by September, October of 2024. And then we'll have the public reporting tentatively by November 2024. So how does the provider report look like? So in order for us to understand the provider report, I'm going to shift gears now and open the Excel file, which was attached in the calendar invite that was sent to everyone in this webinar. So I'm going to stop sharing for a second. Are you able to see my screen again? Rochelle, are you able to see my screen?
Yes, I can see your screen.
Perfect. All right, so this Excel file contains the template for the provider report. And you can see that there are various tabs: the cover page, the table of content, and the various tables that are going to be in the report. So the first tab contains the cover page, explaining a brief overview of the work of the cost board and the first data call that was done in 2022, since this template is going to be for the data that was collected in the first data call. It advises providers at the end. It advises providers to check if the data is reasonable, and that if providers have comments and questions on the data, there are instructions on who to contact to provide feedback. So the second tab contains the table of contents, which enumerates the 8 tables in the provider report. Now let's proceed to table 1. So table 1 contains an overview of the provider's cost growth performance for 2019. Specifically, it shows the point estimate. This is like a fake data that we put in here just for illustration. And then the lower bound of the 95% confidence interval of the cost growth, as well as the upper bound. And then we also put the performance of all providers in the 3 markets, which is commercial, Medicaid, and Medicare, as well as the overall cost growth for all markets. And there are footnotes on like the different methodology, but we'll talk about like how we calculate the confidence interval, like what's the source, what are the data included in the cost growth for providers. So we also provide like a visual on the cost growth performance. So this is on 2019. We don't have the benchmark data yet. Hold on, let me make it bigger. So this is like a sample visual that we will put in the report, and it will show the 95% confidence interval indicated by this blue line, and the blue dot contains a point estimate, and you can be able to look at the confidence interval of the cost growth for each market, commercial, Medicaid, and Medicare, and then compare it to the growth of the overall providers. For 2022 data, when we have the benchmark cost growth, we will include the set benchmark, and you can clearly see your performance against the benchmark. So that's table 1, and then table 2 will contain information on member months by insurance categories, and table 3 will also provide information, same information but broken down by insurance and carrier. Table 4 provides information on total claims expenses by insurance category and carrier, while table 5 contains non-claims expenses by insurance category and carrier. Table 6 contains total medical expense per member per month by insurance category and carrier. And table 7 will contain information on total member expense or TME per member per month by insurance category and service category. And last but not the least, we have table 8, which provides more information on the cost growth, how we calculated the cost growth, and it's coming from the total member expense that is adjusted, which is the sum of the risk-adjusted total medical truncated claims spending PMPM plus the non-claims PMPM, and we'll talk about that in a bit. So that's the provider report template that providers will be receiving for 2022 data call or 2017 to 2019 data. You'll be receiving sometime in late June or July. And then for the 2024 data call, we'll provide the report sometime in September and October this year. So now I'm going to stop sharing and go back to the slides. So starting with 2022 data that is being collected by this ongoing data call, we will have public reporting wherein we're going to compare provider performance versus benchmark growth. And we will do that by comparing the confidence interval of the growth rate of the adjusted total medical expense per member per month to the benchmark growth. So let's dissect some of the important concepts in this phrase. So the benchmark growth, as explained by Rochelle, was already set in the couple, I think in 2020 or 2021, correct me if I'm wrong, Rochelle or Ross, but the board set the benchmark growth to be 3.2% for 2022. And so the next step is for us to then calculate the growth rate of the adjusted total medical expense PMPM. And this one is a sum of the risk-adjusted truncated claims PMPM plus the unadjusted non-claims PMPM, or the raw data that we received from carriers. So later on, we'll talk about how we risk adjust as well as how we do truncation. And we may run out of time, but we have a very detailed documentation of how risk adjustment as well as the other methodologies in the report. The confidence interval, we will need the pool standard deviation or the variance or the square of the standard deviation, which is the variance, to be able to calculate this growth rate. So provider performance versus benchmark will start in 2022 data. And if benchmark growth is less than the lower bound of the 95% confidence interval, then the provider's performance exceeded the benchmark growth. If benchmark growth is within the 95% confidence interval, then provider's performance is indeterminate. And then if benchmark growth is greater than the upper bound of the 95% confidence interval, then the provider's performance is lower than the benchmark growth. So for illustration, suppose we have provider Y in 2022, and this is the blue line contains the 95% confidence interval of the growth rate of the adjusted TME. For the commercial market, we see that the benchmark growth, which is a gray line, is within the 95% confidence interval. Hence, the performance is said to be indeterminate. For the Medicaid market, we see that the benchmark growth is greater than the upper bound of the 95% confidence interval. Hence, providers' performance is said to be lower than the benchmark. And then for the Medicare market, the benchmark growth is less than the lower bound of the 95% confidence interval. Hence, the provider's performance is said to exceed the benchmark growth. So now we have about 20 minutes to go through the different methodologies used. I will explain how truncation is done, and then go through the risk adjustment methodology, and if we have time, go through like how we calculate pooled variance as well as the confidence interval. So for truncated claims spending means that not all spending is going to be included. Specifically, some spending above a certain threshold is not included. The threshold is different across different insurance category and was set such that the total amount of all per member spending above the threshold is about 5% of overall market spending based on 2019 data. And truncation is done based on a per member basis. So for example, we have this, suppose we have a provider, and this one is in the commercial market, and the provider has like 5 members for simplicity, and this is like the threshold for commercial, and the provider has let's say has 5 members, and this is the untruncated claim spending for each of the member. We will compare the carriers who submitted the data will compare the per member per month attributed to each provider, and then compare it to the threshold. If the threshold, we can see here that by comparing member 1, 2, 3 are their spending is below the threshold, hence there is 0 truncation. But for member 4 and member 5, there's 25,000 above the threshold and 50,000 above the threshold for member 5, and hence 25,000 and 50,000 will be truncated out of the spending when reporting for the truncated claim spending. And so the truncated claim spending would be this amount, and if you sum this up, that will be like the truncated claim spending for that provider. Now I'm going to proceed with how we risk adjust the truncated claims spending that we add then to the TME when calculating the cost growth. So adjustment is based on age and sex risk factors and the population weight of each age and sex combination of all the members in a particular provider. Age and sex risk factor is calculated at the insurance category level. We'll show that in a bit using the calculation. So now I'm going to shift gears again and open the sample calculation, the Excel file, to illustrate the steps on how we calculate risk adjustment. So 1 second, I'm going to unshare again. So this is the Excel file that was sent to the group, and this is the steps and example calculation Excel file. So this file provides information like sample data that we can use to be able to use the steps that we calculate when we're trying to risk adjust. And then there's also the steps in how we calculate the pooled variance, and then using the risk adjustment calculation as well as the pooled variance, we calculated the confidence interval of the growth rate of the adjusted TME. And so there is a very detailed documentation on the steps, and this is in the Word file that is also attached. So it's not Word file, but the PDF file. So this one, the demographic risk adjustment, pooled variance and confidence interval of cost growth calculation document provides more detailed information on the various steps on calculating each of these. So I'm going to proceed to this risk adjustment. So these are the steps that you can follow when you go try to like calculate the risk adjusted truncated claims PMPM using this fictitious data that we provide in the inputs. So when calculating risk, when calculating for risk adjustment for the truncated claims spending, what we do is, number one, we first calculate the member months for each year for each provider in each of like the market. So for simplicity, we only have 2 providers, 3 years, and then 1 market in this example. So once we have the total member months, we again go aggregate the data by provider, by ICC insurance category, by year, and by market. So we have the member months, the truncated claims spending based on the inputs of the fake data that we have in here, and then the truncated claims spending and the member months for the market to be able to calculate the population distribution of each provider's ICC for the overall market. And this one is just calculated by the ratio of the member months to the overall member month market for the overall market. So once we have that, we calculate, the third step is to calculate for each insurance category, market, year, the member months again, the truncated claims spending, and then the PMPM for each of these data grouping. Then once we have that, we move to the fourth step, which is to go by age sex band in each modified category. So we have insurance category, the market, the year, and then like the sex codes and the age bands, so the different combination. And now we're going to calculate the truncated claims spending for each of the sex and age band for each of the insurance category. And then we're going to calculate the PMPM, and then link the overall PMPM for that particular insurance category to calculate the age-sex factor weight. So that one is calculated by getting the ratio of the PMPM for this particular row to the overall ICC, and that's going to be the age-sex factor. So for the first row, this means that this is 0.94, which means that for members who are in the group of female age 0 to 1, the PMPM for this group is about 6% lower than the overall PMPM for the ICC for the ICC2 equals 2 group. So that is 0.94. And then if it's 1.04, then that means for female who are aged 19 to 39, 1.04, about 4% higher than the overall PMPM of the overall ICC group. So that's number 4. And I know this is a little bit of like a lot of details, but you can follow it after this webinar and just go through like the Excel file and the Word file to be able to follow this calculation. So once we have that one, the next step is for each age band and sex code provider, modified insurance category, market, and reporting year to calculate now the overall age-sex factor using the previous year by getting the particular HCCTB factor for this row in the previous year. And then we also get that for the current year. And I will explain why we do this thing. So to be able to calculate the HCCTB risk score, what we do is we get the weight of the population for this particular group. And then we have the HCCTB factor. So this one is the population, the member months, the ratio to the overall ICC. So that's the population weight. Then we multiply it with this HCCTB factor. This one is based on the previous year. Then we also get it for like the current year. That means like the HCCTB factor calculated here in the current year. And then we multiply again like the current population weight to the HCCTB factor, and we get like the HCCTB risk factor. Then now we're going to aggregate this thing by provider, ICC, and Medicaid. So what we do is we get the sum of all this group, like the factors, and then it will give us like the overall risk factor for a provider A, in ICC2, in the Medicaid market for that particular year. And in this case, this is 0.97. So overall, provider A's population is like 3% more less expensive than the overall PMPM of ICC2. And then we like adjust, we get like we risk adjust, we divide the truncated claims PMPM by the overall risk factor. And that one is going to be the risk adjusted truncated claims spending. And then we need to group this into markets. So then we will have to like, again, weight that by the year. And then later on, we will group that into Medicaid for provider A and provider B. And I know it's probably really confusing. I think it's best for anyone to like just go through it yourself using the sample data and like the documentation to be able to understand each of the steps. But once we have the risk adjusted truncated claims spending, we have 24.82. And then this is like the risk adjusted claim spending for 2021 based on the HCCTB factor in 2021. So the ones in orange, highlighted in orange, are based on the same HCCTB factor weights, so that any change in the overall risk score from baseline to the current year when we're calculating the growth rate is not due to the HCCTB factor weights, but can be due to the change in population distribution across HCCTB bands. So once we calculated this, I summarize it for 2022. This is the risk-adjusted truncated claims PMPM, 24.82 for provider A. The baseline is 24.67, and then the growth rate is 0.6%. And then I compare it with the unadjusted truncated claims, not risk-adjusted. The raw data that we received from carriers, this is calculated to be, the PMPM is 24.03, 24.02, the growth rate is 0.2%. And now we see like there is like a 0.6 percentage point difference in terms of the cost growth. And this is because like the effective overall risk score for provider A is 0.97, which indicates that members of provider A are relatively lower in terms of PMPM because they are in HCCTB bands that are of lower risk. And so we normalize that the risk adjustment indicates that if provider A has similar risk to like the overall population in that particular market, then this one will be like the PMPM of provider A. For provider B, we see that there is like a negative 5.6% decline in the cost growth based on the risk-adjusted truncated claims PMPM. And this one, the unadjusted truncated claims PMPM is 5.53%. This one is like a negative 0.1 percentage point difference in terms of growth rate. And this one is, you can see that the cost is adjusted downwards because the overall risk score for provider is 1.02, which means that their patient mix are relatively concentrated in age sex bands that are more at risk and probably like more expensive and have a higher PMPM. So to normalize, if they have like the same level of risk as the general population in the ICC, then like their PMPM will be 25.15. And that's how we do the risk adjustment. And so you can follow the different steps in here to be able to provide like more better understanding of the risk adjustment. And we welcome any feedback that you may have on the calculation as well as like the methodology. We also have a sample calculation on the pooled variance. So in the standard deviation tab submitted by carriers, they provide standard deviation for providers. And we have, for each of the provider, we have various standard deviations from carriers. So we need to pull the standard deviation to have like a single standard deviation for each provider. And these steps provide the steps on how we move from having several standard deviation to like one single standard deviation for each provider in each market. So this is like, we have the formula here, and then we have the data. These are all related to the inputs here, the same data. So once we have that, we have the pooled variance for provider A in the Medicaid market for each of the year. Then we can use this data to be able to calculate the confidence interval. And the confidence interval is, the calculation of the confidence interval is detailed in this confidence interval tab. And then this is like the complex formula for confidence interval calculation, but we have a sample calculation with data. And this will provide information on how we get from calculating the risk-adjusted claims spending and then summing it with the non-claims PMPM to get the adjusted TME PMPM. Then we use the pooled variance to calculate the lower bound of the cost growth of the confidence interval, as well as the point estimate and the upper bound. And then we will compare this growth to the benchmark starting with 2022 data. And I think I'm gonna stop here so we can have time for questions. And again, we have the detailed documentation and the Excel file provided so you can study the methodologies outside this webinar. And I think that ends my presentation. Oh, one last thing, Rochelle, sorry. 1 second.
I'm just checking the attendees right now for you, Cheryl. It's hands.
Okay. So I think this one is also the slides on how providers can provide feedback. So when you receive the report, and if you have questions on the underlying individual carrier data, please contact the appropriate carrier and copy us at this email address. And then for all other questions, feedback on report methods and others, again, please email us using this email address. And that ends my presentation, Rochelle. Thank you.
Thank you, Cheryl. If we have any questions at this time, just feel free to raise your hand, and then that way we can allow you to talk. Okay, it looks like we have one.
Two, I think I see 2 hands raised.
Okay, yes, Mike.
Hi, this is Mike DeMoss with Providence. If I understand correctly, if services are provided at a carrier that is not listed, then it is not included in this model. Those services are not included in this model.
It will be included under the large provider entity 999, which means they're unattributed to a provider. So there's still going to be those claims, those spending are still going to be included in carrier reporting, but not in a particular provider.
So even if that provider is, let's say I have a border hospital in Spokane, the patient is attributed to a Spokane provider, but they end up having services in Idaho. Would those Idaho services be included?
No, this one, this program only includes spending on Washington residents done in the state. Is that correct, Ross? Please correct me if I'm wrong.
There we go. I will double check the technical manual. What I'm fairly certain is all medical spending for Washington residents.
Okay. Thank you.
Okay, the next hand is Dominic.
Okay, can you hear me?
Yes, we can hear you.
Okay. Hi, I'm Dominic Stahaley with VMFH. I kind of was piggybacking on was it Mike's question, the patients who are unattributed to a provider. Most likely they're unattributed because they have very low spend. They're not seeing anybody. Are they included in the benchmark overall? And it kind of sounds like they are. So it's lowering the benchmark for everybody.
They're going to be, yes, they're going to be part of the overall spending for the carrier, but not necessarily for one of the 33 large providers identified in our reference table where we identify those large providers.
Is there any, that's a separate question. Is there any geographical adjustments done? For instance, Medicare reimburses a lot more in King County versus the rest of the state. Is that included in there at all?
No, so the only adjustment to the cost growth reporting would be based on number one, like we truncate based on like the threshold, and we also adjust based on the age and sex risk, but there are no other adjustments done when we're calculating for the performance.
Got it. All right. And then last question, the PMPM spend, so a patient is attributed to a provider, but that PMPM spend includes all spend on behalf of that patient, regardless of which providers they were seeing. I just want to verify that.
Ross, do you mind responding to this one? I think the answer is yes.
So there is more detail in our technical manual, but we have carriers attribute covered lives to a provider through use of a hierarchy. That hierarchy is along the lines of member selection. So members who you can easily attribute to, such as a MCO or something along those lines. Contract arrangement, that probably makes more sense for the MCO style that I mentioned. And then utilization. So members that are utilizing that particular provider the most. And this utilization is done just to group these people by providers in order to try and figure out where the spending is going.
Got it. That's slide 20, right, on the webinar. Is that a standardized, the utilization history section of it? Is that standardized across all carriers?
So that membership attribution hierarchy is standard across all carriers for Washington. Yes.
Thank you.
Thank you.
Okay, and one last hand I see is Mark.
Hi, Mark Manti with Vancouver Clinic. Have you, as the board, kind of put together a template for how this information would be displayed when you do take it to public? Is it similar to what we're going to see in this first round, or is it going to be dramatically different?
We don't have a particular template yet, but once we have a template, that's something that we can share. If we have like another provider reporting webinar for the 2024 data call.
I don't see any other hands at this time, Shariel. I'll just give it a minute to see if anyone else has any additional questions for the last few moments of the webinar. Okay, one more. Dominic?
It was mentioned earlier, there's a technical manual. Is that on the website?
There is, Russ, maybe it's good if we can share it in the chat.
I will share the data call resources. It has both, it has the technical manual, the template that we ask everybody to submit in, as well as a FAQ. Let me see if this works. Everyone. Hopefully you all can see that now.
Thank you, Ross, for putting that in there.
Welcome.
Well, it doesn't look like we have any other questions at this time. So I just wanted to remind everyone again that this webinar is being recorded. It will be posted on our webpage shortly for your reference. You can always go back and view this at a later time, or in case anybody within your organization was not able to attend, you can always direct them to that link as well. And if you have any questions at all following this webinar today, if you need any additional information, please feel free to use the email address that Shariel provided to contact us. And we will be in touch with any follow-up questions that you may have that way.
And to add to that, Rochelle, again, we welcome feedback from providers. So if you have any feedback, please kindly email it to us, and we'll do our best to respond to those feedback, and if necessary, incorporate any feedback in our reporting.
Well, thank you all so much for your time today. We appreciate it. And like Shariel said, we encourage feedback. So feel free to use those email addresses to follow up with us. Thank you so much.
Thanks, everyone. Bye-bye.